So thank you, everyone, and welcome. We're going to talk today about embedding digital change in mental health. But before we do, obviously, I'll skip Steve because he's already done his own intro. But if we could just do some intros, please, starting with Ben.
Morning, everyone. I'm Ben Rigg. I'm Director of Digital from Lancashire and South Cumbria NHS Foundation Trust.
Yeah, so it's James Reed. I'm a consultant forensic psychiatrist right here in Birmingham, so welcome to this fair city. And I'm also the CTIO at my trust, where I've been for about 13 years doing that job now.
Yeah, morning everyone. I'm Sean Alcock, Head of Health and Social Care Systems at Millen's Partnership Foundation Trust.
Brilliant. Well, thank you very much for joining us, and hopefully an interesting session. We'll try and leave time for some questions at the end as well from the audience, so please be thinking in advance. But if we could start with, obviously hot topic, there's a lot of discussion about AI in healthcare at the moment. What have been initial thoughts or concerns about its growing role in mental health in particular? Maybe Sean, if we could start with you.
Oh, I'm into the deep end, right? Okay. So yes, AI is very, I guess it's very tricky for lots of people. There's lots about the governance of it, the IG, the ethics, and especially, I'm from a digital team, and a lot of the time digital is seen as a blocker to some of that, but actually digital is not as big a blocker as most people think. It's all of those other things that are in there. I think for me personally, when I start to look at AI and mental health and what it can do, I think it's about looking at that predictive analysis and that prevention. How might we look at anticipating or preventing suicide and things like that. But when we start to talk about that, we get into the realms of class 2 or even beyond device certification, and I think that's always a bit of a blocker or always a contentious part along clinical safety and things like that. So I think it is a tricky area really in terms of how do we get the most value out of it but do it in a safe and manageable way. So I think there's lots of good there. I think there's some simpler examples about how might we do AI triage, call handling, some of those other things that are maybe a bit more established or safer to adopt. But I think the true beauty lies in when you can do some of that preventative or predictive analysis.
Ben, is there things that you might add to that one as well?
So I think every supplier, we probably see it here, everyone's got an AI tool. So we need to be really careful that we're not just going to hoard loads of AI tools and we've got this patchwork of different solutions doing different things. As I think Sean said around the ethics, the governance is really key. You need to make sure that the solution's safe as well clinically, and make sure that you're not putting crap in and crap out. You need to have your data quality right. Now, there could be some really big benefits with things like ambient dictation where your data quality will improve because of the data that's going in there and it's being checked. But also the processes and the variation needs to be dealt with before you kind of scale them up.
Absolutely. And on that point about the quality, what are the benefits and the way that we can support clinicians in their daily work, James?
Yeah, so I think, for me, the thing that with AI to make it work is about concentrating on what it's good at. And of course, when we talk about AI, what we're really talking about these days mostly is large language models. And obviously what we have a lot of in mental health is language. We've got thousands and tens of thousands, goodness knows how many words of stuff locked up in our Rio dating back 15 years in some cases that, although it's all there, in real life it's inaccessible because no one's going to read it all. So I think one of the most useful things for this will be to actually go away and dig through and summarize all this stuff, because the data quality isn't necessarily that good. I mean, it varies, but a large language model is capable, deployed correctly, of doing a much better job of that than we are. And I think where it works best is when we focus on the tasks it can do well, and it can certainly do that well.
Yeah, absolutely. And as technology partners and as the technology advances, what can people such as ourselves and other technology partners do to support that journey and keep it clinically safe and focused on patient care? I mean, Ben, maybe let's come to you first.
So in terms of, is that supplier partnerships? And
so maximising the benefit, but what do we need from partners?
We need to make sure the tools are safe, obviously. So we need to make sure that we're not putting anything out there that's not properly tested. As James said, there's a lot of data in there, and a lot of definitions, a lot of tools and terms that we use. So we need to make sure that it's not giving bad advice, and we're not giving things to teams that just expect it does everything for you. It needs to be a support tool. So I think working with suppliers, we need to work with suppliers to make sure they're safe. It's not just all for the supplier to go, there you go, crack on. We need to do that as a partnership. So there needs to be that industry partnership in place to be able to test things, do them at small scale. Don't particularly like the term pilots. If we can do them at small scale and then, be able to scale them up quite quickly, I think that would be the best way to do it. So making sure they're safe, partnership, and small tests before deploying wider.
Sean, how important is that partnership working to you at your trust?
Yeah, I think it's really important, and I think we would all benefit if we had, again, national or regional opportunities to work together as trusts as well, because I think we can overcome a lot of those issues that are blocking us, right? If as a collection we can, clinically assess and safety assess some of those products that are out there, or for them to already come pre-assessed as such, and then we do our own due diligence for, adoption and deployment. I think that'll help to move things along a lot quickly, because then there's a confidence there to adopt things quicker, whereas everybody trying to do things in silo with their own governance processes, IG and all those things, everything just becomes, 3 or 4 times slow because there's all those different barriers to get through, I guess. So I think when suppliers can be pre-assessed and part of maybe regional or national procurements, that should really help everybody, I think.
And Steve, just coming to you from the obviously the partner perspective, how important has it been to work with individuals such as the trusts and in that partnership working perspective on this journey?
I think it's really important that, frankly, your EPR provider's on the hook with you with this in this journey. It's the Wild West out there at the moment in AI, and frankly, every Tom, Dick and Harry is now saying, yeah, we offer AI solutions, and some of the stuff, the governance around some of them's pretty poor. I think the MHRA aren't making it any easier, because to get your CE1 rating, you're just producing a load of documentation, and we've looked at some of the documentation with other suppliers, and let's just say it's variable, to say the least. And I think the problem with the MHRA, the rules on which it becomes from CE1 rating, which is simple summarisations, and moves into complex summarisations requiring CE2, they're very opaque. And I think if we're not careful, we're all collectively going to suddenly find ourselves, we've moved into the CE2 world without a CE2 rated device and approach. So I think for safety, we've decided we will move to CE2 anyway, because that's about a 12 to 15 month process, and I think we've got to do that really to make sure we've got all the bases covered with the customers.
Yeah, absolutely. And I think those, like you mentioned earlier, Sean, that IG, that governance, and is it going to be a medical device of the future? How do we forward plan to be ready in that case?
It just gives people confidence, right? If we know that there's a certain level of certification and classification, then it makes it a lot easier to adopt versus, is it quite right? Is it safe? And you can spend months just having that conversation around, is it safe and can we adopt it, versus if, there's that right certification in place, it's so much easier. Yeah.
And in terms of what have been the biggest challenges and successes in embedding lasting digital change, not just AI, but can we kind of talk some specific examples of maybe projects? I mean, James, let's come to you first, of something that's been maybe a challenge or a success of embedding digital change within the team.
Yeah. Well, there's plenty to choose from. I mean, I imagine you're probably all sick of hearing me talk about our digital wall platform, but that's still one of the things that we've done in my trust that I'm the proudest of, in that we've been able to pick an area of clinical work where there's a lot of real need. So in our case, this is started 10 years ago, but it was looking at inpatients as an area were not well served, and to some extent still aren't particularly well served by the products that are out there. So everyone, externally, I think a lot of people think mental health care is all about community, and of course it is, but it's also about inpatients, and I'm an inpatient psychiatrist at heart, really. So we did a lot of work to build something, but it was a good example of where you've got clear clinical need and then buy-in from the staff, where the thing you're delivering is not just a piece of technology, it's changing the way they do their work and making it better. Because in our case, it started off with a therapeutic observations platform, but because that went well and was adopted, we're able to then quite quickly build on all sorts of other things. So it now does physical health observations, blood glucose monitoring, tissue viability, Section 17 leave, and all the other things that anyone working in inpatients will be familiar with. So it's a combination of having good technology, but then proper clinical buy-in and leadership, and then delivering solutions to real-world problems. And I think those, if you can do all three of those things, you've got. I mean, you can't always, because sometimes the problems are less well drawn. But in that particular case, we were able to deliver a properly designed solution to a genuine problem, which actually made people's lives easier. And if you can do that, you're on to a winner.
Yeah, and on that point about, delivering solutions to real problems, Ben, have you got an example that you could share?
So there's a lot of guys here who can probably talk about it in more detail. So Rio Recharge is one we've done recently, which was an optimization of Rio, obviously. So background to it, obviously you move on to Rio, you get everyone on it, and then everyone wants everything added, and then before you know it, you've got a beast, haven't you? So we're really strong, the guys here, really strong engagement operationally, clinically, to really define what we need on Rio. And it's really difficult because everyone's got so many different specialties in mental health, haven't we? Different use cases, different needs, and different requirements that need to report on as well. So we're kind of phase 2 or 3 at the moment, but the big phase was around really stripping back all the documentation to a new core set of documentation. And it all started about a year ago, wasn't it? In an improvement week where we got all the teams at a football stadium in Lancashire, not in the actual stadium, in the in the hospitality space, and we just went. The team just drilled through the problems that we've got, what we need to fix, what documentation we do need, and we stripped it back to this new core documentation. Now, if it was digitally led and just digital did that, it wouldn't have been a success. It needs to be operationally and clinically led, and that buy-in's really helped. To maintain, that's very difficult though. So going into the later phases now, you've had that bit. It's kind of how do we continue to get that and make it mean something, because it changes. It comes with fatigue, doesn't it? And digitally, you constantly need to keep doing that, don't you?
Keeping momentum.
Yeah.
And Sean, what about in your area? Is there particular challenges you've addressed or successes that you could tell us about?
I guess some challenges. So one of the big transformations that we've done over the past couple of years is around aligning to digital capability framework and moving that along. And with that, saw us taking lots of different products and different things along the way. And I think it's just always important to make sure that we understand the why of the product, right? Why is it that we are delivering this? And too often, again, as some of our digital project managers or any project managers out there, they can focus on functional outputs rather than the why. They can say, why are you doing this? Well, I want video consultations. That's not really why we're doing it, right? We're doing it to facilitate, equitable access within healthcare, or to reduce journeys, or to reduce burden, or those travel and all those things. So I think it's key understanding the why of what we're doing, and then working, as we've said, with the right people, and really selling that why, communicating that why, getting people enthused, because without that and without the people and that adoption, it doesn't really fly. And we see examples and we see showcases today of some people standing up and saying, we're doing this amazing stuff with certain products from Access Group. And then for us internally, I'd say it's not the same story internally, because we haven't got that engagement. So clearly the products are working, but the engagement and the why and the adoption is a different story, So I think it's just key to get that why right with it. Yeah.
And Steve, that point around understanding why, but also addressing real challenges, how important is that when you're thinking about how we're working with customers going forward?
It's interesting, isn't it? I think suppliers get seduced by their own applications and think, oh, we've done a great job building this application, it solves all their problems, and we almost have handed it over and said, there you go, it's brilliant, isn't it? And we've forgotten that that really that's only half the story. The other half is how are we going to introduce that digital change with the clinicians? How are we going to engage the clinicians with it? And I think we've been guilty of just kind of leaving that just to the trusts. And some trusts are very good at it because they've got people that are particularly skilled in that area, and others aren't so good at it. So we've got to do a lot of work still within our business to make sure we can provide the right levels of support on the change you're doing. And I practice what I preach. I personally go out and see trusts. I went down to Mark's place at Berkshire a year or so ago to look at how they'd implemented their patient flow, because they've had a lot of success, and understand what the lessons learned from them and what are the key factors for it. I've just seen something on LinkedIn around NLFT and about how radically they've improved their patient flow. And it would be easy to sit here and access and think, well, that's all down to our software, isn't it? But it isn't. I know what they did there and how much effort they put into managing the change down there, and that's what's really led to their success.
On that point then, what would be kind of the one or two key things that need to be in place ahead of starting a major transformation project, in your opinion, Steve?
I think really understanding what does success look like for this organisation. What are the smart measures, the specific measurable outcomes that you want from this, and how do we measure that going forward and making sure we're delivering on that, and where do we need to adjust the sails and change direction slightly to really make it more effective. And I think it's not about us walking away when we switched them on and said, well, they're live now, that's our bit done. It's not. We need to continue to work with the trusts and understand that is this delivering through, and if not, what do we need to change with it?
Mm. And James, you mentioned that around, solving a real problem. Is there anything else that you would add in terms of those couple of things that absolutely need to be fundamentally in place?
Yeah, I mean, it's a bit of a cliche, isn't it? But you need to have the technology right. You've got to have the team right. You've got to have the transformation right. Those are the 3 T's, if you like, because you can't do it if any of those three things are missing. Because again, so often, as you know, these things are regarded as technology projects or IT projects, and you just turn a one inefficient process into another inefficient process, unless you're willing to use a wactorism to reimagine the work. And I think that's the thing that we still find difficult. I have to say, one of the challenges you find, particularly when your system is the new thing in town, everyone's talking about it, everyone's got an opinion, when it's been there for 15 years like ours has, it's more difficult to get people to think differently, because they just say, well, it's how it is, it can't be changed. And that's the biggest challenge, is your implementation, if you like, is planning for the war, but then you've got to plan for your peace that's going to run for many years after. How do you continue to do that? And it's hard.
Yeah, absolutely. And Ben, you mentioned obviously getting the operational clinical teams as well as digital, and that maintaining that momentum, like Jane said. Is there anything else that you'd?
It needs to be talked about everywhere. So, as James said, that gets more difficult the longer these solutions are in place, doesn't it? Because when something's new and shiny, everyone's excited about it. But the last thing you want to do is do something and then you're bored or surprised about it or have not heard about it. So it's from kind of cheesy, isn't it, from floor to board, really, that everyone understands it. If you look for us as an organisation, we've got 450 sites across the whole Lancashire and South Cumbria. And if you look on that on the map, it's huge. So it's how do you get that messaging out there to the majority? You're never going to crack everywhere, but how do enough people know about it? How are enough people involved in it where it's going to be delivered and it's going to make sense to them? And the board being signed up to that and being part of it, I wouldn't just say signed up to, being part of that is really key, because they can drive that message, they can support it, sponsor it, all those kind of things as well.
Yeah, and Sean, you mentioned earlier about, people really understanding the why. What do you do, and what does success look like in terms of, enabling those teams to understand more about the real reasons behind what we're doing?
I think it's about understanding that up front, but then communicating that. And it's tricky, right? Because you have to have the right beliefs or set that out from the start to be able to then communicate that. And then hopefully that communication should stand up, right? And it should then resonate with people. If the message doesn't resonate with people, we've probably got the message wrong. So it probably means we shouldn't be implementing something, right? Because everybody just wastes loads of time and money doing it versus invest it in where there is engagement and where people do actually want something. And I think for us, in terms of once we have delivered on something, it's not just then move on to the next. We have a digital change team that then supports that with floor walking or further support, to a couple of months after we've done some of those implementations, so that then that support and that adoption really embedded, rather than sort of just project managers and teams and project teams that just move on to the next thing. We still struggle with benefits realisation. It's been a big focus for maybe the last 12 months for us, and we've had various training and various courses, but it's still very hard to set that out and put those true benefits and the true why up front, and then start to measure them afterwards, because there is such a demand to try and move on to the next thing. And obviously doing that benefits realisation towards the end, it can be tricky, and people might not want to engage or want to move on, but it's so important to understand that, to know if we can move on as well, actually, because why keep moving on to lots of failed things as opposed to understand, have we succeeded, and reiterate and just become a bit smarter of not just waterfall projects, but then iterative value delivery, I guess, really. So, yeah.
Absolutely. And I think, we all mentioned there the importance of communication. So I just wanted to touch on, more around the communication between teams. So as in not necessarily from a digital perspective, but communication more broadly within your organization and kind of what that looks like. How some of your digital projects may be supporting the joining up of not just the data, but the people. Have you got anything that you could maybe talk around like some of the challenges with inter-organisation communication? So, health and social care, inpatients versus community. What are some of the challenges that you face as an organisation on communicating between people? Maybe, Ben, can we start with you?
Yeah. So it's a range of things, isn't it? I mean, it starts with the referral coming into the organisation from partners. We haven't cracked that. We've got a wide range of different kind of referrals coming in, a lot of paper, a lot of emails and things like that. So we're trying to do some work around that. And then obviously between community and inpatients as well, in terms of what comes out of a MDT huddle and from an inpatient discharge into community and things like that. So it's a challenge, and the challenge is the variation, which we probably all see across all the different teams. We open and honestly, we've got teams in Preston and West and Preston East, and when we go and process map them, it's a CMHT, they do things completely differently. So the communication obviously coming out of that is then varied. So it's a challenge. We've trying to do some work around it. Core documentation will help with that, but there's other solutions digitally that we need to put in place to support teams to do that, but we need to know what the problem is with it that's going to solve it, rather than just sticking an alert system or a communication systems in that we think will solve it.
Yeah, absolutely. And James, from a clinical perspective.
I mean, the irony is, isn't it, that communication has never been easier, probably. We've never had more tools and yet, strangely, I don't think the lived experience is that it's actually any better. In some cases, it's worse. You get people saying things like, "Dear X, see this patient, it's all on Rio, yours sincerely," which is, as anyone's ever been on the receiving end of those kind of letters, that's incredibly unhelpful. And we've kind of almost, in some respects, we've lost the art of clinical communication because we just think all the systems can do it. So the real challenge to us, I think, and is to get people to remember what the essence of their role is. And a lot of the time, is something like a referral. What your skill as a clinical person, hopefully, is that you can produce a short summary that communicates what it needs to, and that. It's not the technology, it's about what you're doing. The technology enables it. And I think the mistake we've sometimes made is we've just assumed that the technology is the communication, but the technology is just the vector, the mechanism by which you move it around. And the easier it gets to do, we should be then have more time and energy to spend on our clinical craft, but haven't we done that? If you look at referral letters written between hospitals and GPs 50 years ago, say, they're works of art, and I think that's something that we've perhaps rather lost. So what we should be doing now is saying, well, we've got all this technology that enables us, we need to be focusing back on doing the clinical job really well and writing a really good referral that makes sense rather than filling lots of boxes. And that's a challenge for us as the clinical workforce, I think.
Mm-hmm. And as a operational digital workforce, Sean, is there anything you'd add to that in terms of some of those challenges that maybe come from the teams?
Yeah, I mean, I guess it's always going to be tricky when you've got lots of systems. We've got hundreds of systems, within MPFT, and trying to bring some of those pieces of information together so that we have a consolidated view. It is actually very difficult. I mean, some of the things that we've been working on for the past couple of years is around convergence. So, as simple as that is and as boring or old as that is, it's still very valid, I guess, is to say, well, let's converge, because we can invest lots of time and effort into smaller areas or one area that then benefits lots of people. So I think there's levels of convergence that can happen there. And that's a real tough journey for change, right? You can have a reluctance straight away. No, we always use this system. We love this system. That other system can't do. And we had those challenges. But then actually we're at the end of some of that convergence where we're moving from one system to Rio. And they've said, actually, it's not as bad as what people were saying. Do you know what I mean? And so I think sometimes, again, it's about overcoming some of those misconceptions, and then and helping with that convergence and getting people connected in that way, which then again facilitates, the investment that goes into that then facilitates more time to care, because there's lots of other integrations and things that we've got going on.
So you mentioned, James, in particular about, that difficulty of, bringing things together and understanding, like to Sean's point about that convergence, information is siloed in lots of different systems. What are the risks of having people not being able to, have information when they need it in terms of the access?
Yeah, I mean, obviously the risks are always that you're not going to make the best decisions you can if you haven't got access to the information in a digestible format. I mean, there's loads, unfortunately, of examples of things going significantly wrong. Particularly, I mean, obviously, I was a forensic psychiatrist. I've seen quite a bit of this, and when you dig into it, what you find is usually not that there's been some terrible dramatic error in it. It's usually just that the patient hasn't received a particularly good standard of care, and that's often because the information that's needed isn't available. And I think it's a good start. I mean, my trust, as many, is a matter of public record. We implemented Rio back in 2010 because of a homicide, the notorious case when a policeman was killed on a towpath, and one of the obvious problems with that was that the notes about the patient were in an office in North Birmingham, and then the patient was seen in an office in South Birmingham. And that was what led us to put electronic records in the first place. So that certainly helped. But of course, it doesn't solve the problem on its own. You've got all the information together, but again, the next stage is actually making sense of it all. And the longer that time's gone on, the more of it we have, to the point that you can see it in theory, but you've still got to be able to make sense of it. And if you're not able to do that, we will have more problems. And I do think now that, I think perhaps naively, we used to think, well, we'll just everyone can read the notes, it's fine. But of course, we have the problems that reading the notes, as we've said, takes an awfully long time. And that's where I think the new technologies we're seeing will perhaps finally allow us to aggregate what's important together in a way that helps people make good decisions.
And on that point, Steve, in terms of, data being available, shall we say, the data is there, it's just how do we access it? What are your thoughts on actually making it a lot more of a proactive system in terms of enabling people to find the data when they need it much more easily?
Yeah, I think if it was just about data, shared care records would have solved the problems years ago with it, and we wouldn't be having this discussion right now today. But I think healthcare is probably one of the few industries in the world still that predominantly works off what I would call a pull information environment, where the data and the systems are only as good as clinicians choose and when to go and look in there and pull information out, which for most of their jobs, most of their daily lives is fine, right? But it's when these incidents happen and somebody needs to be informed of something. Right, we need to be proactively pushing out to tell people about things that affect their patient or their schedules or whatever. Do we start to get that real success? How many times do we hear, in the press and amongst your clinicians where they say, well, the left hand doesn't know what the right hand's doing. Well, the data's there. We're just not telling them that there's something they need to be informed of. I was with a customer a few weeks ago, and I haven't had a chance to drill down into more detail with them or with any customer yet on this, but they were saying actually discharges from hospitals that we're not aware of happening, which happen, causes an unprecedented amount of disruption in our schedules, because the first we know about this is that this patient's back at home and we didn't know they were coming out of hospital, so we haven't planned in the things we need to do. So I've got to dig down into that more, but there's a simple thing that could be put in place so that if those clinicians involved in that patient's care were automatically notified on a discharge, they can make their own decisions whether there's anything they need to do, rather than find out later that there's something we should have done. And it just doesn't look good. It's not good for the patient, it's not good for the organisation, it's not good for public perception of the NHS. So it's definitely an area we've got to do a lot of work on, I think, collectively and fix.
And playing devil's advocate slightly in terms of the alerts, notifications, obviously working in very busy environments with a lot of things going on, a lot of pressure on those job roles in particular. how do we not go too far the other way and cause alert fatigue where everything's a notification, everything is, being addressed? I mean, Ben, maybe if you've got any thoughts on that.
I would try to reduce alerts as much as possible. I think it's if you've got Copilot and the information is safe and it's tested, and we've talked about all of that. I think there's something fundamental around AI and being able to go and ask for the information rather than going having to find it. As James said, you got to scroll through all these records. So if all that data can be amalgamated and you can ask, an assistant to say, for example, if you're coming onto a shift as a clinician and it's handover time and you're going to be looking after X patients on the ward, you can ask it, what's the key things that have happened over the last 24 hours or whatever. You can ask it rather than right now you'd have to go in and scroll or trust an MDT is going to tell you. I think that could be a real game changer in terms of, we wouldn't have to alert because you could just, part of your role, you would go and ask it. And there's some alerting that will help, but I'm sure there's plenty of use cases in here today where I've done notifications and alerts and it's just gone the wrong way.
Yeah, absolutely. James, did you want to add?
Yeah, I mean, alerts, it's difficult, isn't it? I mean, I think that the thing that they're useful for is when they're directly actionable or there's something you actually have to do. Because the worst kind of alerts are like the CC email, just to let you know, ... And there's a lot of them that are like that, actually. I mean, we've got very few, but the ones we have are where there's something where you actually need to do something right now. For example, if someone's lithium level's too high or their neutrophils are too low. So you'll get an alert for that. And there's something you then have to do about it, or you really should do about it. So we've tried to keep it to that so much as possible. But it doesn't stop everyone saying, well, all we really need is an alert for this, that, and the other. And then, of course, you have to just point out that all that will do is it'll just mean that people won't read any of them and you lose the impact. So it should be that an alert coming in is something important that you actually take note of because it's rare. But then even then, I suppose you could end up with a lot of things that are important. But if the average clinician is not getting these alerts very often, they're much more likely to take them seriously. And that's the approach we've tried to take.
And Steve, from your perspective, how would you
consider
that?
This subject's come up quite a few times. The points James has just made, and I think the conclusion we reached is whatever we do, we're going to have to categorise these things first of all. So we may have notifications, as you say, they're just things that inform you. Alerts are things that you need to be aware of, but you don't necessarily need to action. And then what we might class as high priority alerts, which are things personal to you that you need to action within, hours, not days or months. But also we need to make it flexible for clinicians to be able to receive those different categories in different ways. So I might decide I just want my notifications to my email. I might want alerts come up to me on Teams, but my high priority alerts, I might, Ben might want it in WhatsApp and James might want it on Facebook Messenger or whatever, but we've got to give them that flexibility to configure it the way it works for them as an individual, because what works for one individual doesn't work for everybody. So I think it's something we've got to go down that route, but we've got to be careful how we do it. Otherwise, as James said, we will have notification overload and you'll end up not looking at anything then.
Yeah, absolutely. Some really interesting points so far. I'm going to open it up if anyone's got any questions.
I'm Matt Kent. I'm Chief Nursing Informatics Officer with Oxford Health. Steve, a question or a point perhaps that I appreciate the kind of discharge from inpatient units to community can be a bit clunky sometimes, and my heart sinks when I hear about people not knowing until they're actually at home. I wonder if, though, that some kind of notification or alert system might lead clinicians into a false sense of security, in that I don't need to talk to the community team because they've received an alert. And actually we know that discharge should happen, or discharge planning should happen on the day of admission, and that involves conversations. So I just wondered, there's a gentle pushback, but
I think it's a really good point. And this comes back to about how do you bring in digital change? And, you've got to cover all your bases. It's a bit like, the old Dilbert cartoon where we've set out to build a swing consisting of a wooden plank and 2 iron chains, and we end up with a rubber tyre on an end of a piece of rope. And say, how did we go from this to this? Because it doesn't fit the bill. But This is about digital change and working through the overall processes and making sure everybody understands how have we got to adopt this technology. Because you're quite right, Matt, there is a danger. You just think, oh, well, we've sent an alert now, so everything's all right now, isn't it? But it's not. You've got to treat that as the same sort of level of digital change as all the other things we've been talking about.
I think to your point, James, earlier as well, the importance of still communication. Like, technology is a tool. It's maybe an empowerment tool of, making some things easier, but there still has to be that human connection and that human communication.
Yeah, I mean, I was doing a talk locally lately, and someone asked me so what do you think digital transformation should look like? And there's a painting called The Doctor, which from the 19th century, which was done at a time, I understand, in response to criticism of doctors for not doing anything. And it just shows a doctor sitting with a patient, looking at them and talking to them. That's all it shows. And there's no equipment, there's nothing there. And for me, that's what digital transformation should actually be in the end. It should just be about promoting good clinical practice and the staff and the patients having a proper relationship, unencumbered by all the laptops and all the rubbish around the edge that we have at the moment. That's what, if we're getting it really right, it should be. And we can
Technology almost
rediscover.
disappears.
Yeah, it becomes invisible, and we rediscover the clinical skills that we've all come here to do.
Yeah, absolutely. Ben, anything you want to add on that one?
Yeah, I guess it's the alert and notification stuff, isn't it? It can be helpful, but it's what follows that, isn't it? So there's the point around, yes, there's a notification, but as you said, a discharge planning should have taken place before that notification comes in, so they should have been involved in it. So it's the workflow, isn't it, that comes with that. I guess it's decision support as well, isn't it, where systems should help you with that decision support. And I think, some of the new technologies, hopefully we're going away from solutions being drove through to get to that point, and actually it comes and supports around good practice and good processes at the same time.
Yeah, and Sean, in terms of that point, is it important that we look at the workflow, the process, and then the technology maps to that?
Well, I think, yeah, definitely, because otherwise we'll end up building things that just aren't valuable to anybody. The conversation around alerts and feeds today, it's going to be so difficult to get that right, and I feel there's a great risk of just completely wasting loads of time in that area, because it's probably less of a shift of that and more making it easier for the person to get to the information. Again, like we're saying, if we've got the ability to ask a question of the system, tell me what the red flags or alerts are, and then all of the background grabs that information, pulls it together. As long as the process and the practice of asking that question every time is in place, which seems like it's a more easier thing to tackle potentially than then building all of these alerts. And again, when you talk about categorizing of those alerts, as soon as you start to get into the territory of categorizing them, you're already saying, well, I've got high that I'll probably just look at and I'll ignore the rest, right? So categorization is it's needed. I'm not going to go, we don't need categorization. We absolutely do. But as soon as you introduce it right, you've already created that concept of, well, I'm going to look at something and not something else. So it's going to be very hard to get right. So process does have to be there, and clinical operations and process need to be there to support it.
Yeah, absolutely. So not quite solved yet then, guys. A bit more work to do on that one.
You become numb to notifications, don't you? How many people open their Outlook and just ping the way the notifications that you've put something important in your calendar or your Instagram page or whatever you kind of...
How many unread emails have you got? I had 20,000, I think, the last time I looked.
So it's very easy to become numb to them, but I absolutely appreciate, there's something that's just how you get that wrap around with it.
Yeah, absolutely. So thank you for the question. There's a question here from Joe.
Hi, Joe McDonald, psychiatrist from Newcastle and member of the advisory board of the Access Group advisory board. The Wright brothers flew their first powered flight in 1903, and we had a man on the moon in 1969. Federal Aviation Authority came into being in 1958. Is there a risk that we're going to regulate AI to death when we should be letting it fly?
I'd say that.
James,
I think it's an interesting parallel, I think. But if you look at, and it's a complicated, if you look at drug development in the sort of the early 19th century, it's the early 20th century, there was a massive surge in synthetic chemistry, and every drug you could possibly imagine was synthesized in that stage. And the regulation of drug trials was, non-existent. I mean, you literally hear about people synthesizing it in the lab on the Monday and giving it to the patient on the Friday. And that led to lots of issues. It also led to a massive wave of drug discovery. We still use drugs that were developed in the 1950s and all the rest of it. And you do worry. And that if you applied the level of regulation we have now, if you look at it on the amount of money spent on drug R&D has gone up and the number of drugs approved has gone down. And similarly, if you read about the discovery of things like a heart-lung machine, if you read about that, there's a great book called The Rise and Fall of Modern Medicine by James Lefanu, and he goes on about this. And the early trials of the heart-lung machine were dreadful. Everyone died, it was a terrible thing. But if you hadn't have gone through that period, you wouldn't have ended up with the sort of work we can do now. And I do feel we are at that exact point. And if we're not careful, all the worry will just mean that we'll just never use it and we won't realize any benefits at all. And it's not on the scale of the heart-lung machine, but I think if people worry too much about things being unsafe, then they won't do it. Because the truth is, these are jobs that will not otherwise happen. Nobody is going to go and read every single Rio entry on any of my patients. They're never going to do that. So something doing it, even if it isn't doing it very well, is better than no one doing it. And if I got a lot of my colleagues to do it, I wouldn't be particularly confident they do it any better than an AI anyway. I mean, that's because human beings, that's how we are. It's a difficult task to do. So I am worried about it, Joe, yes. And I am hoping that we can not throw the proverbial baby out with the bathwater and put this stuff out there and use it responsibly, but not worry too much to the point that we just strangle it at birth, as it were.
And just to add to that, who are the worriers? Who is it? The clinical staff? Is it the management? Is it a combination?
Mix, isn't it?
Yeah. I do think the MHR, we talk about the MHRA, I think they are really struggling to apply the world of blood pressure machines and things to the world of software. That's a real difficulty, I think. I don't think they have the understanding. I mean, we've seen this in other areas. It's a bit like the CQC, dare I say, in terms of our regulators. They similarly don't necessarily understand what they're trying to appraise in terms of software systems. And I think the MHRA are the same. It's not the same thing. And I would like to see a more enlightened approach. I'm a bit nervous, though. They're just going to try and apply old thinking to new technology. And as a result, we'll have some difficulties.
You mentioned, Sean, earlier about, people having the confidence in the tools, though, and, making sure that people are on that journey. If you have anything to add just in terms of how far and how you get that balance right?
Yeah, I think it's hard to get the balance right. I think there is different people are very scared, and we've been almost as society trained, right? You've got Terminator and Skynet and all these things that people go, AI is going to take over, and you have some extremes. But then on the other side, people are like, I use ChatGPT all the time. I want to use it in the workplace. So you have two ends of the scale, and it's really hard to find that middle area of where it's safe and applicable to use or appropriate to use, and giving that guidance. And we're still struggling as a trust. I've got the blessing and curse of being the person that's authored the AI strategy, and people say, you're not moving fast enough, you're not doing anything with AI. And then I'll say, well, what do you want to actually do? And then, I don't know, but it's magical, I just want to do something. And I'm like, well, if you give me some specifics, then we can safely assess it and safely apply that. And then there are others that have a very valid point that will say, well, we just want to summarize information, and we don't want to put clinical information or patient information. We want to structure things and then use those. And again, as a trust, we are still really struggling with that augmentation, really. So we're not talking about replacing what a clinician is doing. We're just talking about how can we augment what we are doing. And we still really struggle with that. And when I say we really struggle, what that transpires to is clinicians going, digital aren't doing enough or aren't moving fast enough, or IT teams aren't. But the reality of it is the reason that the digital teams aren't is because the ethics committees around us and the information governance either are very scared or actually they aren't trained. They never started out being AI experts, so they're completely scared to death of what to say yes and no to. So you end up just saying nothing and standing in the middle ground in a stalemate. And I think it does just stifle that usage and that growth. But I, as an individual, could not be without AI to help me throughout. Even coming on stage today, right, last night, I'm like, I'm going on stage, these are the questions, what can I actually say, or what's something clever or funny or quirky to say? Clearly it's failed, but but even stuff like that, and I see that as a very much a support. I don't come up here and say verbatim what it's told me to say, right? And I think you have to have that common sense application to it's going to augment and support and help me to do what I need to do, right? So,
And Ben, what are your thoughts on Joe's question around are we restricting what the potential could be?
Well, we're potential, aren't we, being in the fax machine world again, aren't we, with the NHS? And in 20 years' time, everyone's like, why is the NHS not using AI? Because we've overregulated it. I think, as Sean said as well, it's about using it as a support tool, isn't it? You're not going to say for ambient dictation, for example, you use it to support. You need to make sure there's safety and things in place, but clinicians, you're not just doing it and then putting it into the record and it goes off into wherever it's going to go. You need to make sure that it's there. It takes that 80% of the effort out, and then you can do those checks afterwards. So it's the kind of hearts and minds of it. In terms of regulation, yeah, I think you need to fail fast, don't you, these things as well. Small scale test, does it work? If it's really unsafe, you'll know if you're doing it with 20 people, won't you? And then you won't go any further. And you're doing a controlled environment. So I think we need to be brave of it, but safe at the same time, and do enough to kind of be able to proceed.
And Steve, in terms of the opportunity that AI brings for, speed, for development, for things that we are working on.
Well, it's really interesting, isn't it? The AI, we're almost expecting it to be flawless before we say we can use it. But humans aren't flawless, right? And the question we should be asking is this going to make less errors than the current process we have with humans doing the stuff? And the answer is almost certainly yes. But we shouldn't be looking for perfection with it. And I think when you introduce things like the MHRA and information governance teams, because it's now an IT system, everybody thinks it's got to be perfect. We're rolling out coding engines. Do coding engines build stuff at the moment as well as AI coding engines? Do they build stuff as well as a technical architect does? No, they don't. They do it to the level of a developer at the moment. But as we said to one of our technical architects, but you're trying to build the perfect whole to the perfect dimensions, right? And this tool can't do that at the moment. But in the time you do that, this tool will have built 8 holes, and you can still stick your fence posts in all of them and put the fence up. So, but the technology will get better as well. All the market surveys are predicting that those sorts of engines we're using now will do the job of technical architects within 12 months. So anything we're doing with AI right now is inevitably going to improve and get better and better. So I think it's a journey I think nearly all of our customers are jumping on, but we need to do it with some caution, is all I'm saying, because the difference in our world is we're not dealing with patients and people's lives, so we can afford to make a few errors in that and fix them along the way. But I think we should be asking our organisations and our IG teams all the time is, is this going to do better outcomes for the patients than the current process with the people? Yeah. That's the magic question.
Or to James's point, actually, if it's not been done at all, is this actually a mediocre next step to add in that process in? Ben, did you want
I was just going to say in terms of that, don't we see some things, it's 98%, so we can't go live yet because it's only 98%. Well, humans aren't 98% accurate, are we? So there's something about, at the kind of you're being pragmatic around it, isn't there?
Yeah, absolutely. Are there any final questions? We've got a few minutes left if there is anybody else. Just down the front here, please. Last question.
Thanks very much. Paul Bradley, of CCI and psychiatrist in Hertfordshire. Earlier on, we're talking about embedding digital change, making it the way that we do things around here. And you were talking about communication earlier. I wondered if you're going to talk about trying to get the message out to people, to your teams. We've all got thousands of staff, and there'll be maybe 10% that will sort of lean in and actually read a message properly. I don't know if any of you have cracked it and managed to get it so that when you do something useful and decent digital change, improve your EPR, whatever it is, people actually take notice, short of literally going round to them one by one and talking to them all, or the much vaunted, but I don't think anyone's achieved it yet, annual training. I know you've been in the running for that for a while.
That close.
The chocolate bar's still waiting to be collected, I think.
James, did you say that one?
Yeah, we are. Yeah, no, we are. Well, we are nearly at the point of having annual EPR training. We've got EPMA. I think the truth is in some respects, digital is just the same as any other kind of change or project. You've got to do implementation properly. It's this old joke, isn't it? I mean, the field of dreams principle, if you build it, they will come. Well, they don't. We know they don't. And then there's high profile. I mean, the obvious example, if I'm allowed to talk about other suppliers, is Epic have got a reputation for being very expensive, but they've also got a reputation for doing implementations very well. And if you look at the way they do it, there's no two ways about it. They spend twice as much on implementation as everyone else does, but they do it extremely well. It's well designed, it's rigid, it's drilled. There's not one person in an Epic organization who's never heard of it or doesn't know what it does. I mean, not one. And that's extreme, but that's the kind of thing you have to do. It's not enough just to build some piece of cool technology. You've got to actually be willing to, bit like you said, to go out there and tell everyone about it and do it properly like any other change, because it won't just happen by magic. I mean, people say this to me all the time, oh, I need to collect this data item. Can you just put it on Rio? And I say, well, yeah, of course, but that's not going to make anyone go and fill the thing in. All it's going to do is put it on Rio, along with all the other 250 things that everyone's told me are really, really important and must go on Rio. And if you haven't got the implementation effort to back it up, it's not going to succeed.
Ben, did you want to add on that with your current project?
I mentioned Rio Recharge before. I think it's that kind of, it's got to be an organisational priority. So you won't get everyone. So it's going to be difficult. But I think in terms of that, it's about organisational priority. So we have kind of organisational engage sessions, got everyone talking about it there. You get your multidisciplinaries talking about it as well. It's not just your digital director responsible for digital. You've got medics and nurses and operational guys talking about it. I mean, it's very difficult. I mean, I think we did a pretty good job in that, didn't we, in terms of that one? But there were still people who would go, what have you done? Why have you done this? But we managed to get probably the majority on that. So I think it's how do you get it, as James said, the kind of, it's the word on the street, isn't it? Everyone knows it, like Epic, it's coming, it's happening. Getting asked the questions around it, maybe in kind of, your operational updates, one-to-ones, all those kind of things. How do you embed it kind of across as many things as you can in the organisation?
And that is about leadership. And again, we've talked about boards before. One thing I've realised over the years is that, having, even if the board aren't necessarily doing anything or having it on their agenda and then them talking about it and talking to their direct reports, and that's the way. If you don't have that, then you can get into difficulty. You can do as much as you like on the ground, but if you haven't got the support from the top down, getting out there into all these channels, then you're going to have difficulty.
Yeah, absolutely. Well, thank you very much. Thank you for the questions. And thank you very much to our panel. If we could thank them in the usual way. Thank you very much.
Nice.
Cool.